Alright, this is just a short video on perfusion index and how we can use it in the EMS or out-of-hospital setting. So let's start with a quick overview. Perfusion index is a measurement that's derived from your SpO2 waveform. It basically is a ratio of your pulsing or pulsating blood flow to your non-pulsing or non-pulsating blood flow. So values range from very low numbers up to 20%. In general, a higher value indicates your vasculature is dilated and that you have adequate pulsatility or good squeeze from the heart, and then lower values would indicate that you have vasoconstriction and or poor pulsatility or poor squeeze. And this is just a screenshot of a Zoll X series monitor showing where you might see the perfusion index on your screen. So the next thing is just in general terms, an overview of when we might use the perfusion index in the EMS or out-of-hospital setting. So I kind of broke this down into two categories. The first is guiding resuscitation, and the next is assessment of pain. Now I came to this conclusion starting with this narrative review. So this paper just looked at a bunch of the studies that have been done on using perfusion index in a clinical setting, and they sort of summarized the various uses here in this next slide. Of those, I think we can break them down into two main categories after we eliminate the ones that aren't relevant in our setting. So again, that would be guiding resuscitation and assessment of pain. Now along the way I did find another narrative review, which I think is actually a little more detailed, perhaps better than the first one. So that is shown here. So if you were looking for one paper to kind of get up to speed on the use of perfusion index in a clinical setting in general, I think this paper is the place to start. Now in terms of perfusion index and resuscitation, we can kind of break this down into a couple different ideas. So the first is we can use perfusion index to determine whether we need to resuscitate or not. We can also evaluate the efficacy of our resuscitation. And then specifically, we can use a perfusion index to evaluate fluid responsiveness. Now I'm not going to get into the details on the specific studies, but I'll just show a couple papers here, and these are all linked in the show notes so you can review them on your own. So here's one looking at the use of perfusion index in guiding fluid therapy and septic shock. Here's another that's describing the use of perfusion index in predicting hypovolemic shock for trauma patients. This other one is about perfusion index and the need for vasopressors. This last one here is about using perfusion index to determine fluid responsiveness. The next thing we can use perfusion index for is to facilitate the assessment of pain. So again, we won't get into details here, but just a couple studies. This first one looked at the use of perfusion index for critically ill patients that are not intubated. This next one looked at perfusion index as an indicator of pain for patients under general anesthesia. But just to show that the data is not 100% consistent, this last paper did not find any correlation between perfusion index and pain as assessed by an alternative assessment tool. So there is some data for using perfusion index both in resuscitation and for pain assessment. So let's just summarize the objective side of these things. In general, low numbers are not ideal. Average, like what is normal, is also a bit elusive, maybe in the 1 to 5 range. And then there is an idea that high numbers, so over 10, maybe over 15, could be associated with some sort of pathology or pathophysiology, but that's unlikely to be a cause for acute concern. If we're using perfusion index to guide resuscitation, consider very low numbers such as under 0.5 to indicate you might need pressors, of course along with other resuscitative interventions. Below 1 or below 1.5, consider resuscitation. And then if you have a notable increase in perfusion index with fluids, that may indicate that you can keep repeating that your patient is fluid responsive. And then in terms of pain, we should see a decreasing perfusion index with an increase in pain, and then an increasing perfusion index with effective analgesia. So a low perfusion index means we need to give more drugs, and a higher perfusion index means we have adequate analgesia. And then we do also want to coordinate this with other indicators of pain, so normal pain and sedation scales, vital signs, that sort of thing. So that's just a quick overview of perfusion index in a clinical setting. But our setting in the out-of-hospital world is a little bit different. So how does perfusion index work in our setting? So there's one of these papers that we mentioned previously that basically summarized all of the factors that could contribute to perfusion index being less reliable. And then I've highlighted all the ones in yellow that apply in our setting. So if we look at this list, we have things like patient positioning, vascular compression, patient movements, external lights, etc. All of this stuff decreases the reliability of perfusion index, and it decreases the correlation between perfusion index as an objective parameter and either pain assessment or evaluating resuscitation. So if we do choose to use perfusion index in the out-of-hospital setting, we just want to be cognizant of these things and do what we can to control them. Okay, so let's end with a quick summary. One thing we didn't mention before is that it's totally fine to use a perfusion index to verify the accuracy of your SpO2 tracing. This is one of the initial indications or utilizations of perfusion index. Moving on from that, in general, normal is a highly variable parameter, but maybe in the 1 to 5% range. But trending is probably more valuable over time versus just a single snapshot or single value. Low values, so less than 0.5 or less than 1, indicate potentially solvable issues. For example, like making sure the measurement is happening correctly, resuscitate, get fluids, initiate pressors, treat pain, that sort of thing. High values, so over 10, maybe over 15, are probably fine, but may correlate with some sort of hyperdynamic pathophysiology. Examples of this would be early sepsis, high output heart failure, unmarked sympathetic response in trauma, that sort of thing. And that's it. There you have it. How to use perfusion index in the out-of-hospital or EMS setting.